For our next plenary, our second moderator, he finished his Doctor of Medicine and Masters in Public Health in Ateneo de Zamboanga University School of Medicine. He took his Masters in Healthcare Administration at St. Jude Colleges. He is a fellow in Philippine College of Hospital Administrators. He is currently a medical officer in the City Health Office of Zamboanga and a Muslim COVID death coordinator. He is also a facility manager in Ecozone Isolation Facility and pursuing his Arabic language and Islamic studies in Mahad Abdiya. No other than Dr. Hussein Sahijuan III. فليتفضل فضيلته مشكورا.
Jazakumullahu khairan, Dr. Shane Al-Abidin Nuruddin, for that generous introduction. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Ahlan wa sahlan. It is with great honor to be invited as one of the moderators for this first Islamic medical conference entitled Medicine in Islam, Medical Practice, and Islamic Medical Ethics. Now let me introduce to you our first speaker on organ donation and transplantation. Our speaker finished his Bachelor of Medicine and Surgery at Medical School, University of Tripoli in Libya. Has a master's degree in Business Administration at Business School, University of Hull in United Kingdom. He is a fellow of the Royal College of Physicians of London. He is a member of the Royal College of Physicians of Edinburgh, the British Renal Association. Also a member of European Dialysis and Transplantation Association, International Society of Nephrology, American Society of Nephrology, and currently a consultant transplant nephrologist at King Fahad Specialist Hospital in Dammam, Kingdom of Saudi Arabia. Let me welcome Dr. Khalid Bil-Eid Akari. Dr. Khalid.
Hi, assalamu alaikum. Okay, now that gets rid of the echo and that shares the screen.
Dr. Khalid, we can't hear you.
Sorry. Hey, can you hear me now? Can you hear me now?
Yes, yes, doc.
Yeah?
Yeah? Yes, doctor. You may take the floor, doctor.
Okay. Okay, thank you very much. Bismillah ar-Rahman ar-Rahim. Thank you for the to the organizers for the invitation. And thank you, doctor, for a very, very generous and kind introduction that I'm not sure I deserve all that. But so it's nice to talk to fellow colleagues and brothers and sisters about the field of organ transplantation and donation. So our journey today, I mean, it is a big topic, and all being well, we'll have an overview. We'll start with an introduction about end organ failure around the world, the size of the problem. Introduce you to the concept of organ transplantation, the benefits of organ transplantations, the survival advantage in particular that organ transplantation confers to the patients. Then we'll touch on the practicalities of organ transplantations, and we'll give you a glimpse of what a potential transplant recipient goes through in the way of evaluation, and issues about organ donor pools, assessment, both deceased and living, and again leave you to ponder about the challenges that the field of organ transplantation is facing. So it has been known for quite a while now that the life expectancy of people around the world has been on the rise. And over the last 50 years or so, if you look at all over the world, the life expectancy of people have been going up. And it's not really limited to one region of the world. Africa, Asia, Europe, Latin America, and North America. The life expectancy of people is going up, improving. That comes with implications. The implication being that we now have more people who are living to older age, and therefore these people. It follows also that these people are, or a lot of these people, are living with remnants of chronic diseases and failing organs, even if it is not an end-stage failure, but failing organs nonetheless. The implication of that is that the medical field and the way and how it approaches this group of the population, it's really by relieving their suffering and treating their symptoms, and to the degree possible, trying to render them functional and independent again. And when possible, and when it becomes necessary to replace their failing organ or their failed organ function. That obviously, is done to various degrees, because the replacement of function of failing organs, is really a spectrum. It goes from controlling their symptoms and alleviating the suffering to actually trying to replace, even in part, the function of the failed organ, the example being the kidneys. So one way of replacing the kidney function is by doing something like dialysis. But when possible also is replacing that organ by doing an organ transplant. This is to give you an idea, by way of example, of the size of the problem that the world faces with end-stage renal failure. So that is kidneys that are at end-stage failure. This is the annual incidence. That's the number of people joining the end-stage renal failure group per million population in various countries. And if you look here, you got Turkey here, you've got Egypt, you get Malaysia here, you got India, you get Tunisia here, and many countries. So it goes from a country like Taiwan, where over 400, around 410 per million population, new patients join the end-stage renal failure group. To in Egypt, it's around 200 per million population. So this is an ever increasing number of patients, and we're lucky in when it comes to kidneys, because there is a way of dealing with this with end-stage kidney failure other than transplant, which is basically by putting them on dialysis. This is something that is not available for us in other organs, for instance, like the heart. Again, as an indicator of the size of the problem across the world. So if you look here, this is the prevalence, that is the percentage of the population that have a degree of kidney failure. Kidney failure is staged from stage 1 to 5, so per age group. So these are the age groups here, groups, so 20-29, 30-39, 40-49 to over 70s. And in percentage terms, it goes from 6% in the younger age group to around 28% in the older age groups. So as people grow older, the prevalence of chronic kidney disease of its various stages, 1 to 5, increases. But on average, across the population, you're talking about around 10 to 11%. And if you translate that into millions, into absolute number of patients, you're talking about just under half a billion, so 500 million in the world suffer from a degree of kidney failure, 1 to 5. So it's a significant condition. That's by way of example. If you home into a single country, like in Saudi Arabia in 2019, there were over 19,000 hemodialysis patients. So around in all on dialysis in Saudi Arabia in 2019, there were over 20,000 people who are on regular dialysis. The number of people on transplant are kind of stayed static. Living with transplant are just over 700. You can see the gap, from 19,000 or 20,000 to 7,000. That's the gap. There's a lot of people who are on dialysis who cannot get an organ. Again, just to show you that even when we are able to provide, a replacement function for the failed organ, like in the case of the kidneys by doing chronic dialysis, a lot of people don't know that actually being on chronic dialysis carries quite a significant mortality. The overall mortality is per year is around 9%. But this slide just shows you that the actually 5-year survival of people on dialysis at times is actually much worse than some cancers. So the 5-year long-term dialysis here, and this is Italian data, is around 55%, 5-year survival overall. Compare that to cancers like colon cancer or kidney cancer or types of lymphomas or even breast cancer. Okay, so having an end-stage organ failure, even when you are able to provide a replacement by dialysis, carries quite a significant mortality. The primary, if you take kidney disease, the primary causes of kidney failure around the world hasn't really changed much over a period of the last 10 years or so. Diabetes is still high in the risk, high in the list there. You got hypertension, you've got types of glomerulonephritis, that's inflammation of the kidneys. So suffice to say, diabetes is the dominant cause. Okay, when when an organ fails and reaches an end-stage failure, what are the options? Well, the options, that we treat the symptoms, ameliorate the suffering, improve the function and functionality of that person, and when possible, replace the function of that organ. Now, we replace it either by a mechanical device, like it's done for the heart to a degree, although it's not widespread. For the kidneys, it's done by permanent dialysis. But when possible, it's with an organ transplant. We replace the organ. So in the case of end-stage failure, we transplant the kidney. In the case of liver cirrhosis or the cancer of the liver, biliary atresia, liver is transplanted. Type 1 diabetes, you get a pancreas transplant. Terminal heart failure, you get a heart, and so on. This slide shows you a milestone of the journey of organ transplantation in the world. These are the first successful transplants in the world. It goes from the cornea, beginning of last century, to the transplanting of kidneys between twins, and then the diseased organ kidney transplant, then came the liver, the heart, until we got to a phased transplant in 2010. Transplant of an organ is a journey. So if you think about it, when an organ, be it a heart, a liver, a kidney, or thereabout, becomes dysfunctional, and it progresses in its deterioration, and it reaches to an end-stage organ failure. You either treat the symptoms, but also when you can't replace the therapy by doing dialysis or doing mechanical heart support. But at the same time, if you evaluate the patient for possible transplant, and there are criteria there, and we'll talk about them later. So if they're medically they're not a candidate, then that will be just basically treating the symptoms and ameliorate the suffering. But if they are an organ transplant candidate, and there is an organ available, then they get transplanted. Transplant then is a journey where they can live with a functioning transplant. Obviously, it will entail taking medication to suppress their immune system in order to tolerate the organ, multiple clinic visits, regular, and tests, and even admissions at times. So what I'm trying to say, right to the end of their life. So what I'm trying to say here is, from being transplanted, transplant is not a cure. Organ transplant is not a cure. Is another mode of treatment. It happens to be the best mode of treatment when it's available and it's possible. But it's not a cure per se, even between twins. Like through this journey, they may suffer complications. So the organ may start to dysfunction or start to reject, or they may have infections, or they may suffer from cardiovascular disease, which is one of the dominant causes of death in organ transplant patients. And also secondary malignancies. So sometimes they suffer from this complication, they get treated and they get back to a functioning transplant, or that organ dysfunction may continue to deteriorate until they get to another state of end stage, and then again, you repeat the cycle again. So there are people who get transplanted more than once. Organ transplantation generally improves the quality of life of the patient and increases life expectancy of patients with end-stage organ failure. That's a general statement. This is some data from New England Journal of Medicine back in the 1999. It again shows a survival advantage of people who get transplanted over people who remain on dialysis. So through all the age groups, both sexes, races, and regardless if you're diabetic or otherwise. So this is the annual death rate. So if you take a group, say the 40 to 59, the annual death rate there is around 13% in this group of people if they remained on dialysis, while if they get a kidney transplant, the annual rate of death is around 4%. So it's around the third of what it would be if they remained on dialysis. Again, the slide shows the patient survival advantage if you get a kidney transplant versus if the person remained on dialysis, and this is a 14-year data. So say after 6 years, this much, so around 85% of people on dialysis are alive, while this figure is close to 90% and in the high 90s for people who get transplanted. So survival advantage right from early on, and it's true even up to 14 years in this study. The survival after kidney transplant has improved as we improved our techniques and our medications. So people who were transplanted in the 80s, that's their 5-year survival curve here. Compare that with those transplanted in the 2010s. So the survival there of more recent transplants is much better. We get better at it. This is data from the US. Again, whether you're, this is patient survival, this is graft survival, that's the kidney, that's the transplanted kidney survival. And again, in recent years, our results are better than what they used to be even in the 1990s. So we're getting better outcomes. Heart transplant, this is 10-year data, but if you look at 5 years, the survival there is over 70% after a heart transplant. For a liver, and this is deceased donor liver transplant, after 5 years, around 85% of people are still alive. It's important, however, that the survival advantage that a kidney transplant confers comes after a while, especially if you're talking about deceased organ transplants. So this is again from the New England paper about deceased donor transplantation in the late 1990s. So if 0 time is the time of the transplant, this is a person who got a kidney transplant from a diseased donor. okay, from a brain dead donor. Now, initially, when they first transplanted, the risk of death actually increases to nearly threefold just immediately after the surgery. And that risk comes down gradually. Okay, in this group, it took around 106 days for the risk to go back to what it was under dialysis. This is for this group of patients in this study. Now, obviously, this period of time may be shorter if the recipient of the transplanted organ are younger and are fitter. So instead of 106 days, it may be 90 days, maybe 80 days, right? But after that, in this group and in this study, after 106 days, the survival advantage is clear. So the risk of death with a transplant organ is less than that of if they remained on dialysis. Well, if transplant is so great, why aren't we doing more of it? Well, part of the problem is really the availability of organs. This is data from the Saudi Renal Registry, the Scott Annual Report from 2019, so that's before COVID. So if you look, this is the number of people who are on hemodialysis. And these are the people who are on the transplant list. So around only 16% of people who are on dialysis are actually on the transplant list. So less than a fifth, 1 in 5, less than 1 in 5 are actually in the transplant list. So there is a gap between people who are in end-stage renal failure and people who are actually on the transplant list. And even these people who are on the transplant list don't think that they're going to be transplanted tomorrow because of the non-availability of organs. Actually, this is data from the US, and this is the median waiting time for a kidney transplant. Around 50 months. In this country is around 5 years, basically, and it varies between blood groups, but on average is around 5 years. For the liver, the waiting list in the US, in the Eurotransplant group is going up. So the number of liver transplants hasn't really changed much, but the number of people waiting for a liver transplant is going up. And there is a gap between the number transplanted and the number who are waiting for a transplant. This is transplant waiting list in the US. Again, quite a significant number of people, over 12,000 people waiting for a liver transplant. For the heart, again, this is US data. Now, over 3,000 people waiting for a heart transplant. What are the barriers for organ transplantation? Well, there are many barriers for organ transplantation, not least logistic barriers and resource barriers. So you have to be able to actually do it. And it is not about a transplant physician, with all due respect, and it's not about transplant surgeon, again, with all due respect to our surgical colleagues. It's really a transplant team. And transplant work is really multidisciplinary par excellence. So you have to have a team. You cannot build it on an individual. It won't work. And as we proceed, you will see why. Other barriers, medical barriers, in relation to the transplant recipient, the patient who needs the transplant. It's really the degree of fitness. So not every person who suffers from end-stage organ failure are fit to actually have a transplant, because you've got, number one, you've got the transplant surgery, which is a major surgery. It's not a minor surgery. It's a major surgery, whether they will be able to tolerate that or not, number one. Number two, they may have a lot of comorbidities that actually limit their survival, even if they get a successful transplant. So, the good news is, okay, you had a transplant, but the bad news is the rest of the body is failing because of multiple comorbidities. And therefore, that person will not live long, even after a kidney transplant, for instance. Other sort of barriers are to do with the donor of the organ to be transplanted, is the availability of the donor. There are issues about consent, whether it's deceased donor or living donor. We'll talk about that later. The fitness of the donor and suitability of the donor. Not everybody who comes forward as a potential donor is accepted as an organ donor. And then there is donor care in the ICU setting, especially to do with the deceased donors. Last, again, under medical is really the match between the donor and recipient, be it the blood group match or the tissue match. But you see that I've left that right to the end because we have solutions for this, but the medical fitness and the availability of the organ or the availability of the donor is a bigger issue. Transplant recipient evaluation. Well, it's quite detailed. I said it's multidisciplinary, so from the medical evaluation by transplant physician, transplant surgeon, there is a transplant coordinator, there is a social worker, there is a psychologist, there's a clinical pharmacist, there is an immunologist, the lab test and the detailed imaging. The aim of the transplant recipient evaluation is to establish that the candidate is well enough to tolerate transplant surgery and is likely to benefit post-transplant. In other words, they're likely to enjoy the fruits of the transplant in terms of quality of life and in terms of survival. But here, quality of life, is a matter of perspective. In other words, what constitutes a good quality of life or an acceptable quality of life for me and you may be different from how the patient sees it or how the family sees it. So, quality of life, but who's to say? Who's to judge what's a good quality of life? Again, the time post kidney transplantation, that is the survival of the transplant recipient after transplantation. That's also something to think about. And I'm going to throw these as questions because these are questions that we face every day when we do transplant work. So, there is no age limit per se for being a transplant recipient. Now we transplant people in their even in the late 70s and occasionally even in the early 80s. But obviously these people have to be super fit, and there are a lot of thinking that goes on around that. Like even if you take somebody who's in the mid 60s, like 65, well, what's their survival? What's their expected survival? Without a transplant. Well, without a transplant, if you take the example of the kidney, the expected survival is around 4 or 5 years. With a transplant, you may add another 2 years for that. So all in all, that kidney you transplanted is going to serve for 6 years. Well, if you took that kidney from a deceased donor, that same kidney could have gone to a younger patient and would have functioned there for 20 years, not 6 years, 20 years. Or if you took that kidney from a living donor, say of age 30, and then that kidney survived for only 6 years because the patient dies of natural causes. So you took that kidney from somebody who is age 30, who is expected to live to the age of 75 or so. You took it at the age of 30, you gave it to somebody else, okay, who needs it, but that kidney only served for 6 years because the patient dies of natural causes. So is this acceptable? So suffice to say that the time and the length of time and after transplant and the quality of life can be quite subjective. So age mismatch, again, okay, so going back to the age mismatch, so we face situations where basically a 20-year-old or even 18-year-old, because that's the legal age for consent in this country. So somebody who's age 18 comes and wants to donate a kidney to a father or a mother who's age, say, 67 or 70. Right, well, you know what I said now about the expected survival of that recipient, and the fact that now this donor, living donor, is going to live with one kidney to the age of 75, because that's the expected, that's the life expectancy at birth in this country now. So it's a question of judgment here that we have to struggle with every day. Again, you've got the issue of comorbidity, so we're dealing more and more of recipients who are marginal, i.e. who are overweight, have diabetes, have a bit of heart disease, you know, multiplicity of comorbidity. There are people who come with history of non-adherence to treatment. You know, how do you deal with those? Do you say, well, you're not transplantable at all if you're non-adhering to your treatment before the transplant? Expanding the organ pool. So from deceased donor, there are two types of deceased donors. There is donation after brain death, so that's brain stem death, and there is donation after cardiovascular death. So they're also known as beating heart and non-heart beating donors. There are specific definitions for brain death, and these have to be satisfied before a donor is accepted. For the circulatory death donor, there are different categories. You know, they go from dead on arrival. This is the Maastricht categorization, to death after unsuccessful resuscitation. But there are also types of cardiac death or cardiovascular death that are planned. The example of that is bad brain injury. So victims of accidents that come with very bad head injury that are incompatible with life. This Maastricht categorization has been modified several times. Now, the deceased donor, well, first of all, there is the legal stipulations, whether the law of the land allows that or not, and what are the diagnostic criteria for to diagnose brain death. So that's somebody who's unconscious without any sedation, who cannot breathe on their own, so they are on a ventilation machine, and who satisfy certain brainstem test criteria, and also a confirmation by an EEG and a cerebral angiogram. There is a question of consent. There is here the donor card. The deceased donor may be a donor card carrier, and if they are a donor card carrier, does the family have a veto on that or not? Or is it final? If I'm a donor carrier and I happen to suffer from an incident, does my family have a veto over my wish by being a donor carrier? There is also the opt-in, opt-out to the donor list. So I can, you know, countries in the world are different. So if you go to Spain, it's an opt-out. So everybody who dies is a potential donor in a country like Spain, unless they opted out, unless they said during their life that they do not want to be an organ donor. So you have to opt out, not opt in. If you take a country like Saudi Arabia, no, it's an opt-in. I have to say that I want to be a donor during my lifetime. Obviously, by being an opt-out, Spain has basically completely vanished its waiting list. The aim in the evaluation or under consideration of a deceased organ donor is really to ensure that their organ to be transplanted is of a decent quality for it to be transplanted, and also there are considerations for risk of transmission infections and malignancy. So this is about brain death. As I said, patient is unconscious without any sedation, no brainstem reflexes, and on a ventilator. But these tests here are quite detailed and have to be done in a certain way, and they differ from one country to another, in addition to confirmatory tests by doing a brainwave recording and an angiogram. Types of DCDs, that is cardiovascular death patients. Again, this is modified Maastricht. The rule there is basically the decision to withdraw cardiorespiratory support when we're dealing with cardiocirculatory death. The rule is that the decision to withdraw the cardiorespiratory support should be independent of that of organ donation. They're two separate things done by two different teams independently. Controversy, again, to do with the deceased donor after cardiac death. Controversy exists really about the time that should elapse after cardiac arrest or unsuccessful cardiac arrest for death to be declared. There's a rule of thumb there that's around 5 minutes have to elapse of continuous cardiorespiratory arrest. That is basically a flat line or asystole before organ retrieval can start. The WHO has issued a critical pathway for organ donation, be it a donation after brain death or after circulatory death. The practice around deceased organ donation around the world is quite variable. As you see, in a country like Spain, the rate of donation is quite high. It's around 30 per million. And these are brain death donors. They do little of circulatory death. Compare that to the UK, where the rate of brain death deceased donors is around 10 per million, and they do more of the circulatory death. And even countries where circulatory death or donation after circulatory death is legal, like the UK and Australia, the practice is different in terms of the frequency of it. And that's, again, it's quite noticeable here that the UK does more of deceased donor organ retrieval after cardiovascular death compared to, say, Australia. But it's noticeable that the number of ICU beds available in Australia is around 70 per million, while in the UK is around 27 per million. So circulatory death or donation after circulatory death, what happens is if it is uncontrolled, if it is unexpected cardiac arrest, so there is the arrest there is the attempt to resuscitate, that if that tends to be unsuccessful or deemed unsuccessful, then there is a no-touch period where you're not allowed to touch the patient or retrieve the organs. After that period elapses, then the procedure for organ preservation and retrieval can start. Now, that's obviously presuming that this is that there is a consent for this patient or for this person to donate. If it is controlled, like the example I gave of a bad head injury that is incompatible with life without cardiorespiratory support, so that is under control. So there's a withdrawal of life support measures here. This is different from brain death. This is somebody with cardiorespiratory support who are not brain dead, but who have severe brain injury that's incompatible with life. So in countries where this is legal, like the UK, they can withdraw the treatment here, and then over a period of time, the blood pressure drops, and they gradually get into a flat line, and there is a waiting period from start of flat line before they start organ preservation and retrieval. For the living donation, to try to expand the donor pool, we went now to do a blood group incompatible or tissue or HLA incompatible transplants. We have the living unrelated and the undirected donors. This is an attempt to expand the donor team. And also in the last few years, we've been doing donor exchanges. The assessment of a living donor, again, it's a medical assessment to see whether they're fit, they're not terribly overweight, they don't have diabetes or cardiac disease, things like that, seen by a donor coordinator, social worker, psychologist, donor advocate, also. There are a series of lab tests and imaging. Again, is to try to establish that the candidate is well enough to tolerate the donor surgery and that they will be able to live normally thereafter from the medical point of view and quality of life. Key to this is the question of consent. Increasingly, we're dealing with marginal donors, donors where the weight is up, they're more than ideal, they're overweight or even at times touching on the obese, BMI more than 24 or BMI more than 30, the age mismatch, and also there are people who come with pre-diabetic state, a tendency to develop that. They're not diabetic at the moment, but they have a tendency to develop diabetes later, or marginal in terms of blood pressure. And there are also people with subtle urine exam findings. The question here, other than the living donor passing the surgery, the donor surgery, which again is a major surgery, it's really the long-term outcome for these, and in particular the risk of end-stage renal disease after kidney donation. So this slide here shows the 15-year projected chance of end-stage kidney failure per age group. This is before donation. So if you look at somebody who's 20, the risk of developing end-stage kidney failure in over the last 15 years is less than 0.1%. For somebody who's 60, the risk is less than 0.4%. So the risk is quite low. This is before donation. If you look at, this is a 15-year risk. While if you look at the projected lifetime risk of somebody to develop end-stage kidney failure over their lifetime, if you look at somebody who's 20, their lifetime risk is 1.6%. Somebody who's 60 and survived so far without kidney failure, the risk during the remaining of their life is around 0.6%. Now, these risks here, so the risk of end-stage kidney failure is in the general population is low. The lifetime risk is low. However, after donation, you have to multiply this by a factor of 3 or even 5. So compared with if I don't donate, my risk of my lifetime risk of end-stage renal failure goes 5-fold. So it's not without risk. The practice of living donation around the world, Saudi Arabia is one of the top countries in the rate of living donor or living kidney donation, around 30 per million. You've got Jordan here, you've got Iran here. Countries where there isn't much of deceased organ donation tend to rely, and there are transplant programs, tend to rely on living donation. This is, again, the proportion of living kidney donation as compared to all transplants. Again, if, like in a country like Egypt, where deceased donation is not permitted, they live 100% on living donation. 5 minutes, yeah, okay, right. Paired exchange, so donor and the recipient, they're not compatible. A donor and the recipient are not compatible. So what happens? This recipient either looks for another donor, or now they can exchange their donor with this recipient. So this is a recipient, they're not compatible with their donor. This is another recipient, not compatible with their donor, but they can exchange. So this can donate to this recipient and this to this recipient. And it can be done for more than 2 pairs. So we've done it to 7 pairs. So 1 pair, 2 pairs, 3 pairs, 4, 5, and 6, and 7. In this center, we've done it to 7. There is also the concept of undirected donor. So somebody who just say, I just want to donate to anybody, they can start a chain. So this is what we call a chain. Okay, and it may end up with somebody who was meant to donate to a particular recipient, but they're not compatible with them. Their recipient took a kidney from somebody else, so it's only fair that they donate to somewhere else. So sometimes they can open yet another chain as big as this one, or even bigger, or go to the deceased donor list. Finally, the challenges that, or some of the challenges that we face daily as transplant physicians to do with the recipients, mostly really to do with the marginal recipients. So people who are in extreme, who are older, people who have multiple comorbidities. None of these comorbidities is basically a no for transplantation, but if you add one comorbidity to another, to another, to another, they add up, the risk end up. The consent, the donor organ quality, the challenge of perioperative risk, as we said earlier, that the benefit of the deceased oral organ transplantation may not reach the patient until 100 days or 90 days after. Question of non-adherence, life expectancy, that's again in transplanting people who are quite old or with multiple comorbidity. The donor, it's really to do with quantifying and expressing the risk. So the quantifying and expressing the risk to the potential living donor of their lifetime risk of end-stage kidney disease, especially if they are a marginal donor. The consent here, consent, if it is a deceased donor, does a card do, or does a family have a veto? Like covert coercion between say, for instance, we see quite a lot of children age 18 or 19 and 20 coming to donate to their fathers and mothers, but are they really making that decision freely without coercion? We go out of our way to try to keep them best informed about what they can and what they can't do. But in the end of the day, they have to come forward to become donors at their own free will. Thank you.